So good morning, ladies and gentlemen. It's my distinct pleasure to be chairing this session, KDIGO 2023 CKD Guideline, A Brave New World on Evaluation, Prognostication, and Management of Kidney Disease. I think many of you know that the last CKD Guideline update was 2012, so this is a long awaited, but we have lots to say, and so stay tuned. These are my disclosures. And today's session, as I said, is chaired by myself, but actually we have three outstanding speakers. My co-chair for the KDIGO Guideline, Paul Stevens from the United Kingdom, Rometsa Kazangaku from Turkey, and Magdalena Madero from Mexico. Each of them will give their talk, and then we'll have questions and answers at the end. So please stay tuned, and I'll welcome Dr. Stevens to the podium.
Great, so thanks, Adira, and thank you for the opportunity to start talking to you about our new guideline update. So I don't have any disclosures, well, no real ones. This is my talk outline. So the idea is not to be exhaustive or exhausting, because we each only have about 15 minutes to talk to you, and I've chosen to take a slightly different approach, and rather than list everything you're going to see in the guideline, I'm going to concentrate a bit more on the why question and talk a bit about these broad areas. So first, let's remind ourselves of the KDIGO mission statement, because I'd submit that that's pretty much why all of us are in this room and here at this conference listening to all the talks. And when we're thinking about global guidelines, then quality of care and removing unnecessary or unwarranted variation and reducing inequalities are key drivers. But there's a massive amount of information out there that we need to assimilate, and anything which makes that easier has got to add value. And at the same time, we want to reduce waste and ensure that money and resource available to us in our healthcare systems is put to the best possible use. And finally, in doing this, we can find the gaps in the evidence that then stimulate further research. And guidelines contribute to the research loop, either directly as we develop the guideline or indirectly through implementation and evaluation. And this should be a process of continuous quality improvement if it's to succeed. So 20 years ago, as Adira mentioned, KDIGO started with a definition and classification of chronic kidney disease, and then KDIGO picked up the baton, thought more about the classification, and the staging, and with the help of the CKD Prognosis Consortium, introduced the CGA concept, thinking about level of GFRG, albuminuria A, but also about cause C. And with the CKD PC data, there was a growing emphasis on prognosis and risk. And as we moved forward, we began to get more tailored therapies to specific causes of chronic kidney disease, better tools to identify chronic kidney disease, and a wealth of data internationally, and also a much better understanding of risk. And then finally, the introduction of therapies, here we go, I knew I wouldn't get that right, much more general therapies to target chronic kidney disease across the whole spectrum. And you're going to hear a little bit more about some of these areas from my two colleagues in a moment. But the big driver, of course, is that globally chronic kidney disease is a major public health problem, as we all recognize, and this graphic from KI Supplements ably demonstrates that. Not just the prevalence of chronic kidney disease, but its growth in ranking as a leading cause of death around the world, but particularly in low and middle income countries. And we also know that the burden of chronic kidney disease is greatest in the three lowest quintiles of socio-demographic index. So it's not just about death, it's also about disability. And disease burden is the impact of a health problem as measured by financial costs, mortality, morbidity, and other factors. And you can measure it by combining those two indicators, the number of years of life lost to disease and the number of years lived with disability due to the disease. the disability adjusted life years, or DALYs. And globally, DALYs have almost doubled over the last 30 years, from 21.5 million in 1990 to 41.5 million in 2019. And DALYs are particularly important when we think about costs incurred by patients and their carers. And these are costs related to work productivity, unemployment, lost productivity due to premature mortality or early retirement. And they don't just affect the patient, they affect the caregiver as well. So they're all compelling reasons for early identification and treatment of CKD, and we'll come back to this later. Of paramount importance, though, is the evidence. And you'll recall that one of the reasons for guidelines is to stimulate research. And one of the problems that we had was that the density of the literature in the field of kidney disease as opposed to the field of heart disease declined linearly as GFR fell. And that's changing. But before the last guideline, if you looked at any of the big randomized controlled trials, you wouldn't find a kidney patient in them. So as a result, we were left with a composite of anecdotal or short case studies which weren't controlled trials, and some reanalyses of one or two of the big trials that did have some kidney disease patients there. But as a result of that, we had a largely opinion-based literature. And as I say, that is changing, and what you're seeing on this slide is the literature published in chronic kidney disease over the last 30 years, split up into 5-year time periods. The numbers in the middle of each column are guideline publications, but it was meant to be orange. It does look a bit orange. The orangey bit at the top are the RCTs, meta-analyses, and systematic reviews. And they've doubled from 3.3% back at the beginning to 6.5% of published studies now. And to put that into some kind of perspective for you, in ischemic heart disease, those figures started at 6.2% in the earliest 5 years, but actually have only increased to 7.9%, so we're catching them up. And as the song would have us believe, there are more questions than answers. But actually, the more we find out, the more we know, and the better we are at working out what we don't know and asking the next set of questions. So since the 2012 guideline, we've had a decade of questions and answers. We have tools to improve diagnosis and evaluate function, and we're going to hear more about this from Rameza in a moment. And we also have exciting new developments in liquid biopsy, imaging, and genetics. There was a session on genetics yesterday. I don't know if any of you caught that. And we also have the new treatments, and you're going to hear about some of those new therapies from Magdalena. But finally, we have big data to address some outstanding issues, and the elephant is on this slide for a reason. So for this guideline, we're again indebted to the CKD PC Consortium, and the data that they've produced now comes from a staggering population base of 27.5 million people worldwide, and also a pretty large subset of nearly 700,000 folk with measurement of cystatin C2, and about 30% ACR across the board. So they've expanded the number of outcomes too, up to 10 outcomes now, 6 cardiovascular, 2 kidney-specific, kidney failure and acute kidney injury, and 2 general, all-cause mortality and hospitalization. So these next few slides are going to be really busy, and you're not meant to be able to read them. They're just there to give you a sense of the direction. So the left-hand panel, as you're looking, is estimated GFR by creatinine and albumin-creatinine ratio, and the right-hand panel is eGFR, creatinine, cystatin C by ACR for each of the 10 outcomes of interest. And the point is, just with the earlier, less extensive CKD-PC work, the adjusted risk for each outcome rises with decreasing GFR and increasing ACR. And that relationship not only strengthens with the addition of cystatin, but cystatin also largely removes the previously observed J-shaped relationship with higher eGFR due in large part to the influence of non-GFR determinants. And when you subdivide the cohorts by age, under 65 on the left and over 65 on the right, you can see the same sorts of relationships. They're a little bit weaker with estimated GFR creatinine alone, but when cystatin C is also used in the estimation of GFR, the relative risks are much more similar by age. And lastly, in this last slide from the CKD-PC consortium, this is looking at results from the eGFR creatinine and cystatin subset for all ages, but looking specifically at the hazard ratios for the G3A category without albuminuria, the GFR threshold for CKD diagnosis. And again, the hazard ratios across all the outcomes are significantly increased. So these sorts of data then segue into a new aspect of the 2023 guidance, which is to think about the special considerations for chronic kidney disease across the whole lifespan, and in particular at either end of the age spectrum. So a personalized approach considering age, sex, and gender for diagnosis, risk assessment, and treatment is critical. It's what we do in our everyday practice. At the extremes of age, the very young and the very old, the diagnostic procedures, the treatment aims, the treatment modalities, and the decision-making are going to differ because of differences in prognosis, treatment options, and prioritization. So children and young adults have very different etiologies of chronic kidney disease to adults, and the delivery of care, including diagnosis and evaluation, will also be different. And there are also these additional components shown on the slide to be considered, and even what may seem to be very simple things, such as the frequency of visits for a patient, may need to be very different during transition to adult care. And the considerations in older adults are again likely to be different, and they present different challenges. And in many countries around the world now, there are significant numbers of adults over the age of 75 under the care of nephrology services. And octo and nonagenarians often demonstrate distinct patterns of disease complexity. And these features include multimorbidity, often accompanied by polypharmacy, frailty, cognitive impairment, and gerontopsychiatric disorders, amongst others. And often, several of these features will coexist in older adults with CKD. So we're in Italy, so here's a little Latin for you. In the past, there's either been a nihilistic attitude to the older adult, as this cartoon is illustrating, or alternatively, because what evidence there was that we had in CKD largely excluded older adults, we made sometimes arbitrary, often subjective judgments about the applicability of the evidence. And happily, we've begun to see a growing evidence base in this population of older adults, making the evidence directly applicable. And these are just two of those studies published earlier this year. The one at the top of the slide is looking at SGLT2 inhibitors in people with chronic kidney disease, stages 3 to 4, hospitalized with decompensated heart failure, who are over the age of 75. And the bottom one is looking at older adults, mean age 86, with mean Rockwood frailty scores of 5, randomized to invasive versus conservative treatment strategies for non-ST elevated myocardial infarction. So changing tack slightly, we also now have tools to assess risk and to aid us with those difficult decisions, such as the kidney failure risk equation or risk models to assess timing of outcomes, and also, but not shown on this slide, we have cardiovascular risk models that are tailored to and incorporate kidney disease factors now, such as QRIS3 and the SCORE. So do these risk models work? Well, actually, yes, they do. And as shown here in this example of prediction of end-stage kidney disease by the kidney failure risk equation, they can outperform both patients, but also you guys. As I said at the beginning, though, I was going to come back to early identification and treatment. We have the tools for early detection and evaluation, and we'll hear more about this in a moment. We also have treatments that add value, and we're going to hear more about those too. So what we do now is we fulfill a lot of the principles for early disease detection laid down by the World Health Organization over 50 years ago now. And we know that given these developments, certain countries are taking another very hard look at screening for chronic kidney disease as a now cost-effective strategy. So I want to thank my co-chair for this guideline, Adira Levin, particularly because I shamelessly stole a couple of her slides, the Guideline Development Group for all their hard work and commitment, and of course KDIGO. Oh, were you expecting guideline statements? Well, you'll have to read the public draft, which is about to be released. Thank you for your attention.
Distinguished Chair and colleagues, and here's my disclosure, and my task is to run through some of the topics that will be covered by the guideline in the short time period. And as Paul was alluding to, this update actually includes the decade-long new evidence to provide the optimal care that we can provide to people with CKD. And we have developments that have been introduced to our clinical practice, which we will be sharing with our people who present to us with chronic kidney disease. So we're talking about the classification, CGA. We all have these numbers or letters that classify some of the things, and we're talking about the cause, glomerular filtration, and albuminuria as the main factors that determine what's going to happen to people with CKD. And the definition has not changed actually with the new guideline. It hasn't changed. But the importance of the classification has been updated or has been emphasized more, because with the definition we have more kidney markers, kidney damage markers in the game, but with the classification it's actually a two-dimensional tool that takes into account the kidney function determined by the glomerular filtration rate and the albuminuria. For the definition, we have to have a proof of the chronicity, which involves many steps actually. But for some, we don't need those steps. The newborns born with kidney disorders have to be labeled with chronic kidney disease right at the birth, actually. But chronicity should be managed or should be challenged because we know that some of the AKI patients present with the same symptoms. So we have to differentiate between these two types of diseases. But while trying to getting a proof for the chronicity, we should not delay the treatment, initial treatment for our people with CKD, because it's critical that we start early and we did diagnose early. Well, while going through the definition or proof of chronicity, we also need to evaluate the cause of the disease in the people with CKD. And we have many etiologies, and we have the standard forms to approach the people with CKD, actually. And it's critical that we identify the cause of the CKD, but it's essential for the optimal treatment for management in the CKD. We have our own tools, old tools, regular tools, working tools, but which can be defined as, for people with CKD, as having an estimated GFR or a measured GFR, or whichever equation you're going to use, and then also looking into the urine analysis to have an idea of albumin over creatinine ratio, and also, if possible, to move forward with more sophisticated tests like using the imaging or the immunological workup or the genetic testing wherever you're living in the world, depending on your restrictions, actually. So another way to move forward with the cause of the disease is to the kidney biopsy. And for the kidney biopsy is still a suggestion in clinical situations, appropriate situations when it is acceptably safe. Because looking into the evidence, actually looking into these 14 studies, the complication risk doesn't seem so much. But this has to be taken into account, as in any care for chronic kidney disease, people with chronic kidney disease, we have to have a shared decision to move more forward with the kidney biopsy, because in some situations, waiting for the results will actually prolong the start of the initial treatment. So with the diagnosis and evaluation, here's another way to approach the people with CKD. And these are the point-of-care testing, POCTs, that are available. And in fact, we have some examples here at the Congress as well. And this is very useful when you have very limited resources to access to a real laboratory, or where the result is very critical at the point where you're providing this healthcare. It could be due to also health economical restrictions. And the POCT devices that we use or suggest to use are related to creatinine and the urine albumin, and they should be standardized and validated as any lab analysis that we use in our daily life. And if you're using a POCT for creatinine, you should have a way to have it report back to you an estimated GFR. And if you're using a device for urine albumin measurement, then you also need to be able to get a result for your albumin creatinine ratio as well. Some of the studies have already used these devices and the results in the general population, looking at this NICE and NIH research reports that looking into populations where it was a need to get a result for the enhanced CT scanning, and it was clearly shown that using these devices in the point of care situation in the clinical actually provided economical benefit for the community. And of course, each system requires an evaluation of the environment that is using this device, and that has to be validated. Looking into the advantages of using newer these testing techniques, well, you could facilitate patients being monitored at their home, remote areas. You could just get rid of the expenses that will be required out-of-pocket money for the people with CKD. And thinking about the COVID-19 pandemic, we could avoid the infection risk for our people, and it's convenient. Of course, there is less need to transport the sample to the laboratory, less sampling, simple analytic process, and we get the immediate results back. And they can be carried out in the primary setting, secondary setting, or community setting, and it will be easier for people to be recognized to have a CKD and be early referred to the nephrology clinics. And especially for the children, you will just need a finger prick sample to get your results back. So now let's switch to the evaluation of the GFR, one of the important components for our people with CKD's prognosis. And what we do is we are using estimated GFR, and initially we're used to using the estimated GFR using creatinine, and that's probably where to start when you're evaluating your people presenting with CKD. And if it's not going to work, and if you have any doubts about it because of the clinical situation of the people, then you're likely to use more advanced equations or estimations using the cystatin C formulas or the combination of those formulas. But you have to be aware that all of these estimations have their restrictions depending on the clinical situation of the people. But also, there is this debate about the use of following up the estimated GFR in the real world, because the estimated GFR will not be exactly sampling the real change in the measured GFR. And of course, there are some issues related to the lab analysis, and you have to make sure that your creatinine or cystatin C has been taken in the regular and the routine way. If you're not able to ascertain your GFR with the estimated measurements, then you could move forward with the measured GFR and take into account what the results are. But also you might run into problems with the timing, so if needed, you could use time urine collections to come up with a GFR, especially in those situations where you're using very therapeutically small drugs to be given to the patients. And what about the labs? And while reporting the eGFR, of course, we need our serum creatinine to be measured, and we ask every laboratory to report an eGFR with every serum creatinine that has been measured in their lab. And we recommend the labs or the hospitals or the clinical settings to report an eGFR of less than 60 mL per minute to be flagged as low, to make sure that everyone understands that there's a risk going on and to do the proper things. And of course, there are some issues related to the processing of the blood samples, and it should be done within the 12 hours. So taking into account, if you don't have any resources to do that in 12 hours, if available, using POCTs is definitely better than using the real lab. And of course, this all requires the calibration, evaluations, validations that are required of standard care. If we're going to use the cystatin C, on top of creatinine, serum creatinine has to be there, because we would like to have a combination of these two to have an estimated GFR rather than versus each alone. And of course, the clinical laboratories should have the validated resources to do these measurements. For the pediatric population, if the clinician has the current and accurate height, then the appropriate pediatric formula can be applied to those pediatric population, and the eGFR less than 60 mL per minute in the children over the age of 2 can be presented as a decreased GFR in the pediatric population as well. While Paul has shown you the newer heat maps, which I'm not going to share with you, but we had started like a decade ago with this map, and we have moved forward and improved it, including many markers and making it more precise for the individual per se in terms of the risks related to the chronic kidney disease. And we have improved, we have integrated age and other markers to make sure that we have a better outcome measure for each of our patients, actually. And then these, of course, as you can guess, require validated risk equations, and many of them has been actually validated with many of the studies. Here's an example, and this is for kidney failure replacement therapy risk, and the other one is a 40% reduction in the GFR, looking at the different estimation equations and having an idea of how this person is going to move forward in terms of their CKD. And these are the numbers that have been alluded to, these studies, the equations. We have many equations looking into the use of them in clinical practice, and we can say that we can use many of them, including creatinine. Of course, if you're using the cystatin C formulas, we need to move forward with some of more validation studies, because this has been only done in Europe, and we need to control it in the other continents or in other populations as well. A couple of these risk equations for predicting kidney failure in the general CKD population, and this works for stages G3 and through G5, and especially the KFRA, the kidney failure risk equation, is the one that is mainly used with 4 variables or 8 variables, and it has been shown to discriminate any other effect and is quite remarkable to use in our daily practice. Some more equations looking into the prediction of 40% decline in kidney function. These are important because we want to know what to do with our patients in the future. And these equations showing the risk of 40% decrease in the GFR has been validated in the US health system, and you could use them for including many more markers in the equations to see how the people with CKD will move forward. So in turn, we have ended up with this pyramid where we have different kinds of risk equations pointing out to the outcome of the people with CKD. And in short is that if we have a 3 to 5% in the 5-year kidney failure risk of our people with CKD, we should refer them to the nephrology clinics or where the nephrologists are. If we have a risk of kidney failure, 2-year risk kidney failure, 10%, then this person needs multidisciplinary care to make sure that they progress slowly. And if they have a 2-year kidney failure risk more than 40%, now it's time to program the kidney replacement therapies or timing of vascular access for these people. But please I want to remind you that this also works for other groups of patients, and Paul actually talked about them. Many of the other risk equations, including cardiovascular outcomes, mortality, have included people with CKD, so we have better equations to look into our general population presenting to us. But thankfully, we don't need to memorize any of these. We could go into websites or the applications or the available resources to see how people with CKD will progress through. Here I stop, and I will be happy to take questions at the end. Thank you.
Good morning, everyone. Thank you for the opportunity to speak on behalf of KDIGO. I would be discussing the interventions and complications of chronic kidney disease. This was a very long chapter, so it was hard to summarize in a few slides, but I'll do my best. These are my disclosures. All right, so we're gonna start off with a case, and this is a typical case we see in clinic. This is a 63-year-old man with a history of hypertension and dyslipidemia. who presents to the clinic with the following labs. He has a BUN of 48, a creatinine of 2.4, estimated GFR is 32, he has a uric acid of 9, albumin to creatinine ratio of 380 milligrams per gram, bicarb of 19, and a potassium of 5.1. He comes in with slight hypertension, BMI 27, so, usually typical case that we see in clinic. He's on rosuvastatin and telmisartan. So the question here would be, which of the following interventions might have an effect on the progression of his chronic kidney disease over the next 3 years? So I want you to raise your hand. Should we control his blood pressure less than 120/80? Should his uric acid be reduced less than 7? Should we increase his serum bicarb more than 22? Shall we start on an SGLT2 inhibitor or all of the above? So who's voting for E? E? All right. So that is not correct, okay? And I will show you a little bit of the evidence of why this is happening. All right, so we know that blood pressure control is great, and we learned from SPRINT that patients that have been randomized to the intensive treatment have actually a reduction in cardiovascular outcomes and mortality. However, these outcomes in SPRINT CKD, which was a subset of patients, 2,600 patients, did show that reduced blood pressure intensive treatment is associated with a reduced risk of composite cardiovascular disease and all-cause mortality, but no effect on kidney disease progression. And this holds true also for the diabetics. So, we do this for cardiovascular and all-cause mortality protection, but not for kidney disease progression, which was the question I asked. So the patient is started on dapagliflozin 10 milligrams a day, right? So the most reasonable action for follow-up would be, should we monitor his potassium 2 weeks after starting treatment? Monitor his eGFR 2 weeks after starting treatment? Starting the patient on an SGLT2 inhibitor should not modify the usual monitoring of kidney function, or shall we monitor uric acid, eGFR, and potassium 1 week after starting treatment? So what do you all think? Okay, good. All right. So that's a big take-up point. SGLT2 inhibitors, we expect an initial drop in GFR. They're not associated with hyperkalemia. On the contrary, potassium goes down, uric acid goes down. So no need to monitor extra, right? So that's something we're saying in the guideline. All right. So this is what we're going to say. We recommend treating adults with CKD and heart failure and an eGFR more than 20 with urine albumin to creatinine ratio more than 200 with an SGLT2 inhibitor, all right? We suggest treating patients with eGFR between 20 and 45 and UCR less than 200 with an SGLT2 inhibitor. And this recommendation is not as strong, and I'll show you a little bit of the data. All right, so this is the effect of SGLT2 inhibitors. This is a meta-analysis, a systematic review published last year, where you can see that, overall, kidney disease progression, reduced significantly along all trials. So this is diabetes and non-diabetic trials. When you look at cardiovascular mortality in CKD, you can see that, again, you see a benefit here for cardiovascular death and cardiovascular hospitalizations. However, the big issue here is that it's only EMPA-KIDNEY that treated patients with low albuminuria. And the primary endpoint was not met for EMPA-KIDNEY in that category of low albuminuria. And when we look at slopes, at least long-term slopes, you can see here that regardless of the level of albuminuria, you still see a protection. So, GFR less 1.37 versus negative 2.75. So you're halving it in half. But however, these outcomes are not hard outcomes and have not really been approved by the FDA. So, slopes are not what we expect for, a recommendation that would come as 1A. And that's the reason why it didn't come as strong. All right, so, this is very similar to the diabetes guideline. We switched a little bit this figure. So, you can see we have lifestyle at the top, so healthy diet, and I'm going to be talking about a little bit about diet at the end. But first-line therapy for most patients, SGLT2 inhibitors. Sorry, this is the diabetes guideline. For some reason, this is not my last presentation. I'm just realizing. But anyway, it doesn't really change as much. But we're going to say RAS inhibitors and SGLT2 inhibitors as first-line therapy, and then for diabetic patients with a persistent albuminuria, normokalemia, non-steroidal MRA. One important thing is that we have no data for finerenone or non-steroidal MRAs in the non-diabetic population. So we are not coming up with any recommendation or practice point on this, and this is just going to be a research recommendation, right? And then you need to have antiplatelets, so cardiovascular protection with antiplatelets and statins. We're only saying for secondary prevention, not for primary prevention. Statins, yes, for everyone, but aspirin, not for everyone, only for secondary prevention. So who and when? So as I said, GFR more than 20, ACR more than 200, heart failure patients or diabetes, regardless of the level of ACR, so diabetics should go on the medication regardless of ACR. And we need to educate patients about hypoglycemia risk and volume depletion risk. And hypoglycemia risk can be managed, decreasing insulin and decreasing sulfonylurea, or medications that are not going to have an outcome, are not going to have an effect on outcome. Volume depletion risk is very debatable, but if a patient is coming with volume depletion, makes sense to reduce diuretics to be able to continue the patient on these medications. And the reason why this is helpful is, well, we know that we have afferent vasodilation. This is a diabetic nephron, and that we have a reduced feedback from the macula densa. So this generates hyperfiltration. If you put a patient on an SGLT2 inhibitor, you normalize glomerular capillary pressure because you increase this feedback from the macula densa, because you are not getting sodium and glucose back to the macula densa. You're losing it in the urine, and you have a reversed afferent vasodilation. And these are a few of the mechanisms of, why we are seeing all these effects. You have a reduction in, this is what I just told you about in the previous slide. You have a reduction in blood pressure. You have a reduction in LV wall stress, increased oxygen delivery, decreased oxidative stress, and so on. So these are a few of the mechanisms why these therapies are helpful. So, if you have a patient that has not been treated, right, a diabetic patient or a patient with albuminuria, you may lose 12 mLs per minute. If you put them on a RAS inhibitor, you lose 4.6 mLs per year. But if you put them on a combination, you actually decrease this risk by more than half. So potassium. This is data from the CKD Prognosis Consortium. We have learned that, as expected, when your GFR goes low for non-diabetes and diabetes, you may have an increased prevalence of hyperkalemia. But, this is even more marked when you have higher albuminuria. And what we're saying here is that for actions to manage hyperkalemia, so when you have potassium more than 5.5, first line you need to optimize bicarb, optimize glycemic control, consider loop diuretics and SGLT2 inhibitors. Second line, dietary restriction. We're not suggesting that every patient on CKD should go on dietary potassium restriction. only if they have hyperkalemia. And the third-line medications, we have all these license exchange resins, such as patrimir or sodium zirconium cyclosilate, that could actually help us keep our patients on the drugs that are going to have an effect on their outcomes. So this is what the guideline will come up. Again, no data for non-steroidal MRAs in non-diabetic CKD. We also have no data on steroidal MRAs, so spironolactone has really no effect on kidney disease progression either. So uric acid, unfortunately, this is evidence-reviewed team. This is, there's really no data in all those randomized controlled trials that lowering uric acid actually has an effect on progression of kidney disease. So what we're saying is just treat patients that have gout, symptomatic hyperuricemia, but not in asymptomatic hyperuricemia to delay chronic kidney disease progression. Metabolic acidosis, again, very similar to what I show you with potassium. As you have more albuminuria and your GFR decreases, you have a higher prevalence of having a bicarb level less than 22. However, if you look here in the top at the randomized controlled trials that do have placebo and bicarb, there's really very little, no effect on bicarb progression. So we are saying that, we should treat when the bicarb goes below 16. And that's it. Monitor patients to ensure correction of sodium bicarb does not result in concentrations. So make sure if you're going to treat it, the patient's blood pressure doesn't go up. Monitor fluid status, and so on. Diet. So the patients always ask this, right, at the end. So what kind of protein intake would you recommend? So shall we restrict protein to 0.4 grams plus keto analogs? Shall we restrict protein to 0.8 grams per kilo? 0.6 grams? Plant-based protein, no restriction. So what do you all think? A? B? C? D? All right, so we're going to stick with the 0.8. And the thing is, this is what the old guidelines say. And, the most recent KDIGO guidelines came back with a 0.5 to 0.6, so a lot of restriction. And this was graded as 1A. We actually, as a group, did not agree with this recommendation. We thought that the evidence is really not that good. Actually, if you look at the evidence, this is a Cochrane review for change in GFR. It's very low. And, again, most of these trials are old, were done before RAS inhibitors and SGLT2 inhibitors were implemented. So, we thought that protein restriction, severe protein restriction, may be counterproductive. Patients have low adherence to these diets. So we're going to stick with the 0.8. Plant-based diet. This is... yes, for some reason the slide doesn't look very well, I'm sorry. So plant-based diets, actually, there's a little evidence on this, and, moving from DASH diets, moving to DASH diets or Mediterranean diets or plant-based diets, may affect outcomes in terms of CKD complications such as hyperphosphatemia, acidosis, hyperkalemia, and progression of CKD. Again, this is very preliminary, mostly observational data, but, our recommendation for diet would be more of plant-based and, more of Mediterranean DASH diets. And we think the quality of the protein is important, not only the quantity. We know red meats increase, a lot of cysteine and methionine and, maybe associated with worse effects. So we're also now focusing on the type of the protein, not only the quantity. All right, so in conclusion, SGLT2 inhibitors are indicated for CKD, ACR more than 200, diabetes, regardless of level of ACR or heart failure. Potassium management is key to continue RASI or non-steroidal MRA treatments. Newer agents can help optimize potassium management. There's really no data to support management of non-severe metabolic acidosis or asymptomatic hyperuricemia. There's new data on lifestyle, diet, and CKD progression, although most of this is observational, and I invite you to read through the whole chapter. This is only, the tip of the iceberg. This will come out for public review soon, so thank you for your attention.
So this session is now open for questions. It is the public review of this document, which is over 300 pages long, I believe, is going to be available in your inboxes at some point in the next couple of weeks. So look out for that. But we now have time to ask and answer some questions.
Thank you very much for the excellent effort that has been taken with these guidelines. My question is from practical point of view. About the point of not following the EGFR soon after initiating the SGLT2 inhibitor. What I have noticed from my practice, it's not uncommon to see a significant drop in the GFR to the degree sometimes more than 50%. And the workup showed no evidence of any other cause of acute kidney injury. And after I stopped the SGLT2, the EGFR improved dramatically. And the patients sometimes themselves, they are shouting at me, I do not want this medication. I know the long-term effect, but just my concern is why we are not supposed to follow the EGFR soon after the initiation of SGLT2. Thank you very much.
So thank you for your question. I mean, this is an important and relevant point. And I think, mostly GFR, the thing is, we're going to see a GFR drop, but it's not like RAS inhibitors where we need to chase potassium, right? So, we know these medications for the most part are safe. And, unless the patient is volume depleted, right, then, okay, the medication needs to be stopped. But, if you look at the meta-analysis, you can see a decrease even in AKI by 28%, and this is, looking at all 13 trials, right? So, we think this is pretty safe. What we don't know, for instance, is if we should start them at the same time, right? That's mostly a research question. Should we start an RASI and RAS inhibitor and SGLT2 inhibitor at the same time, or shall we start first one and then continue with the other? There are places where they start them at the same time. But, because they do not cause hyperkalemia or, no changes in other electrolytes, then, it's considered safe.
It's another.
Sorry, it's the same questions. I'm sorry, there is a specific recommendation what to do with them in the setting of AKI?
Yeah, well, you need to stop the medication, yeah.
Great.
This was actually my question regarding the guidelines for avoidance of AKI. In the cardiologists, they often start 4 medications at the same time, and they show that actually the sooner you start multi-therapy, you get a better prognosis. I would like your comment in the context of the kidney function.
Yeah, so I think cardiologists are much better than us in implementing, right? Like they were told, we have these 4 fantastic drugs for heart failure. Patients get on these medications. I don't know, nephrologists, we're much more cautious about it. We don't have data about, starting them all together. So that's more of a research question. Yep. But, one important thing is that, if the patient does have AKI or volume depletion, and, we're talking about this sick-day rule, where the patients stop the medication, then it's very important that the patient gets back on the medication, because we have a lot of evidence that a lot of the times these medications are stopped and never restarted.
Have you looked at the threshold for risk for contrast media?
The GFR?
Threshold, the GFR threshold for contrast media risk.
Threshold for contrast?
Oh, the threshold, like 30% decline?
No, the threshold for decline.
Is there any EGFR level beyond which you would recommend not to use contrast media?
No, in fact, we were very clear in the guideline that we should treat our patients as you would anyone else and weigh the risks and benefits of any investigation with the benefit you will get from the answer. So there's no recommendation.
Sorry, to add to your Reply back, actually, for the EGFR, for contrast media or imaging, there's another chapter in the guideline you're going to see, and that's more critical. The outcome for the patient is definitely more critical than looking into the equation. So you have to do whatever is needed for that person in that critical situation.
Yeah.
Thank you.
There's a question in the back there.
Yeah, just while that question's coming, it was one more point about blitzkrieg therapy or sequential therapy, and that's about knowing what's causing the effect. So it's not just the beneficial effect, it's sometimes the adverse effect. And if you introduce everything all at once, then you don't know which of the therapies you need to be stopping. So a little bit of sequential, personally, I think is better than a blitzkrieg.
So short questions and short answers. One, two.
About the prognostication tools, you discussed about preparation for renal replacement therapy, but maybe I missed it. Have you talked about starting therapy in regard to these tools, to these calculations, or simply about the end-stage kidney disease preparation?
Sorry, the risk equations work for the people with CKD as soon as you start with the therapy, but planning your therapy will always require how this person is going to do in the near future, in 2 years' time, in 5 years' time, what is expected of him or her in the future. So we have to take into consideration everything related to that person in terms of optimal treatment as well.
Right, because specifically when you discussed about the patients with lower albuminuria, the guidelines are not, let's say, fully committed to some of the therapies. So I ask if we have tools that might convince us that we should start these therapies for these patients.
Definitely. That's going to help you with persuading that person to start with the therapies that you suggest is going to be critical for them.
Okay, thank you for this great session. I'm Samah Idris from Egypt. Actually, I have a small commentary because I attended in Sweden the consensus of ADA KDIGO during the ASD last year. They said there is a rationale behind using the renoprotective agents in a sequential manner. So we should avoid the excessive renal dipping in the initiation of the medication, which is reasonable in the real-world practice. Plus, the rationale behind using all the 4 agents, the 4 pillars in the cardiology, because we have a very short window of opportunity. It's a maximum of 30 days, and there is a risk for the life of the patient. So I think we have different rationale than cardiologists. Thank you so much.
Thank you for that comment.
Yes.
Questions over here?
I was surprised by the bicarbonate recommendation. Don't we worry about the bone? Don't we have enough evidence about acidosis and being deleterious to the bone?
There you go. Oh.
Thank you for your question, and I understand your concern. And we looked closely at this evidence, and there was really no data, not even for other outcomes than the progression. I mean, the evidence is not strong, even for bone, nutrition, muscle mass, which are other important outcomes where bicarb had. I mean, no strong evidence. So we couldn't really come up with a recommendation for this.
Speaking about strong evidence, I'm here on your right. Thank you.
There you are.
I was puzzled about your recommendation on lowering the blood pressure below 120 based on the poor sprint trial, who didn't met the less than 120 itself in trial conditions. So why did you think that we might do it in practice and real life? And why is that still a recommendation?
So
for with and without diabetes.
Yeah, so I mean, I think we would, most of the blood pressure stuff, we're just referring to the 2021 guideline. But we know that the blood pressure needs to be automated when measured in clinic, and we're just, referring to that. So your question is that, why are we lowering?
Why are you still using this less than 120 when sprint trial condition of measurement doesn't mean only automatic, but also a lot of relaxation before and after, and a lot of things that we cannot do in the real life?
No, I agree. And that's been a huge criticism, but this is beyond the scope of this guideline. We're just...
But yourself, you said that you will protect the heart, which is okay, what
Yes.
we do with but what about the kidneys? We are also the doctors for patients with bad kidneys anyway. So maybe the cardiologist can do this with normal kidneys, but for CKD, I don't think this should be a target anyway.
So I think we're taking care of the whole person and to reduce cardiovascular risk. And the chapter is entitled Management of Complications of CKD, which includes cardiovascular disease complications. And so I think it's a guideline for the person.
I know,
and all we're saying is that there's the data for lowering blood pressure to reduce progression of kidney disease does not exist. So that is not the rationale for it. The rationale is for the person. But we certainly appreciate your comment, and it will go out for public review, and we'll take into consideration everybody's thoughts.
You.
Thank you. Over here, last question.
Thank you very much. Yes, I think that is different if you see for the quantity of protein and the calories you give for a patient grado 4, see? Because I come from South America, and it's so different. We see a lot of patients with protein energy wasting and a lot of loss of mass muscle. So if you see a diabetic patient that is like that, and you have an albumin of 2.83, and he's going to dialysis, it's not better to give a little bit more of proteins. In that case, in that case, plus a quantity of calories than to give 0.6 or 0.4 plus ketonalogous? I say, we are so different than in Europe. Perhaps we need Latin American guides. Perhaps.
Do you want to answer?
So there's specific bits in the guidance that you'll find when it comes out for public review that actually recognizes the problems with protein energy wasting and essentially not doing harm to people. So we're not big on protein restriction at all, and if you go into the pediatric part of the recommendations, then you'll see quite the reverse there, because clearly growth is incredibly important.
So I will encourage you to read the guideline, because the excellent job that our three speakers did with a 15-minute snippet didn't at all give you all the nuances. And I think above all, the guidelines say these are statements that need to be taken in context of the person in front of you. They very much need to be applied to an individual circumstance. There's no intention to prescribe one thing for the whole world. It's very nuanced. And in a 15-minute presentation, it was very hard to get that across. But thank you for raising it so that we had a chance to describe
and
that.
there is a practice point exactly about that, right? No protein restriction in those that have sarcopenia.
Have sarcopenia.
Thank you.
Yes, very good point. Thank you. Any other questions? I want to thank then very much all of you for listening, but to our three excellent speakers.